I'm very honored that Dr. Kawi was willing to come and present here. I had read an article in during the course of my research, and I was so impressed by it. It was so concise and clear and easy to understand that I wrote to the author and asked her if she would present at the symposium, and she was gracious enough to say yes. Dr. Jennifer Kawi is an associate professor and alumna of the FNP program at the University of Nevada, Las Vegas School of Nursing. She's a board-certified APRN with a specialty in chronic pain management. She teaches primarily in the graduate programs. Her research line of inquiry is in chronic pain and opioids. She has received various awards and written several publications with her expertise in chronic pain. We are honored to have her. She's our first plenary speaker all the way from Nevada. Please welcome Dr. Kawi.
Thank you. So I'd like to think that I brought the weather here. It's actually 50s there in Las Vegas right now. So yeah, it's a good weather. This is really nice too. I like this. I'm so used to those big podiums and you can barely see. So this one I can actually see people. So really, really great. Thank you, Teresa. I think that was a nice foundational talk that provides a great segue to what I'm going to be doing today, and we'll try to stay on time. Oops, we lost the time frame on here. It went to a movie thing. So anyway, my training in pain management came right out of my NP practice. So back then in about 2003, there weren't a lot of primary care opportunities. Right after I graduated from UNLV, most of the openings for nurse practitioners were in specialty. So pain management was one of them. So it wasn't really a choice. I got put into it, but I developed that passion later on down the line to where in 2007 I proceeded and advanced my education, did my PhD, and then did my research and dissertation in chronic pain. So done quite a few publications. One of them was what Teresa was talking about. This was written in 2013 to 2014 in the Nurse Practitioner Journal, published online 2015, and then in print 2016. So it's a little bit of an older article already. And as you know, with technology and statistics and data information nowadays, we've progressed and we move forward. So we're gonna give you some update on these things. But the main focus of my part here is to look at those current guidelines and standards of care in the management of chronic pain. Can't hear me very well? Okay, is that better? Yeah, all right. And then we're going to integrate these guidelines in discussing practical strategies that are systematic approaches when you're caring for your patients, particularly chronic pain patients in the primary care area. So those are our main focus for this talk. I have no conflict of interest to disclose. Teresa gave a really good definition of chronic pain already earlier. So it's a sensory and emotional experience that our patients have. It can go from anywhere from, when we define chronic pain, depending on the reference that you're looking at, it can go from they can say 3 months or 6 months. If they say 6 months, a lot of it, they would say it's more than half the days of the 6-month period or an almost daily basis on a 3-month period. Either way, as she had mentioned earlier, it's about the delay in the healing time that normally happens when you have an acute pain. And so that's pretty much where we define chronic pain. There may or may not be a clear etiology for it, and it becomes really frustrating for our patients when they don't understand that there is no cause or we can't figure out what might be causing their pain. And we see that a lot when we order some x-rays or diagnostics, for example, and we tell them, well, there's really nothing here, yet they're having pain. But pain is a subjective experience, and so we believe them, we manage them, and then we go from there. Okay, pain is what they say it is. So here's just a quick case scenario before we get started. 65-year-old female patient with back and leg pain presents to your clinic, aggravated by walking after 2 blocks, relieved by sitting or leaning forward. And then during physical exam, there's limited range of motion on the lumbar spine, pain with extension of the lumbar spine. So relief when he extends, or pain when he extends, and a little bit of relief when he actually flexes. Negative straight leg raise test and no neurological deficits. Likely diagnosis. If you look at these things, It's easy for us sometimes to hone in right away on neurologic and muscular differentials. We have to remember that there also might be other system issues that happen. So for example, vascular claudication. It's a vascular issue. It's related to decreased circulation due to arthritis. It almost causes the same symptoms as what this patient is displaying. And so for that matter, I just wanted to make a point that when we do look at these patients, we don't right away hone in on the musculoskeletal or neurologic issues, or primarily musculoskeletal. So based on these choices right here, what do you think might be a likely diagnosis? What's your working diagnosis, for example? No brave soul just yet. It's too early. Well, let's keep going in the interest of time. So we talked about vascular claudication. Reiter syndrome is a reactive arthritis issue, and it's related to arthritis joint types of pain. We have joints in our spine, the facet joints, but this patient is having some radiation, right, in terms of the leg area. So that might not be what's going on here. Vascular claudication, if I just go back in it, a lot of times for these patients who have vascular types of pain, it's easily relieved by rest, unlike when you have neuromuscular types of pain issues. Let's skip spinal stenosis for now. Herniated disc at L5S1. A lot of times these patients have radiating pain. If you follow the dermatome L5S1, these patients will have pain, pathologies, and radiation all the way to the toes or the heel. That's because of that L5S1 dermatome. So it may not be the most likely issue here. And then we have mechanical low back pain. Mechanical meaning those joint structures, soft tissues, and even the disc cartilages and areas of the back. That causes a lot of pain. But for this kinds of pain, usually they're not radiating down to the leg, maybe just the buttocks, the thigh, not so much down the leg, and definitely not down to the foot. So in this case, usually spinal stenosis is what we think about, especially for those patients who have pain with extension. So pain with extension, if you think of the anatomy, the disc spaces then get smaller when they extend, whereas when they flex, it actually widens a little bit. And for those kinds of patients, they actually feel some relief. Just a little bit of case to kind of get us started, okay? All right, statistics. Teresa talked about the Institute of Medicine earlier in 2011. This is a really huge seminal report. If you want to learn about chronic pain a lot, that's something that we use a lot in terms of citation in our pain literature. Back then, the statistic says 100 million. Now we're looking at about 120 million. So that pain prevalence is increasing gradually. And when they reanalyze that data, when they look at it, the 125 million or so are those who have pain within the past 3 months. When they look at those who suffer from daily pain, there's at least 25.3 million. And then those who suffer from a high intensity of pain, that's about 23.4 million. So if you look at that huge number, the 125 to 150, almost you're looking at 1 in 2 adults. So 1 in 2 people in here have symptoms of pain or pain issues within the past 3 months. And that's how prevalent this issue is. And it has, instead of getting better with all the technology that we have, it hasn't. It's actually gotten worse. So here are other statistical information. Low back pain is pretty much the most common arthritis-related issues specifically. These are really, really important statistics. The pediatric population, Teresa talked about the adolescent population. Pediatric population now globally, 20 to 40% already are also having a lot of pain complaints. Musculoskeletal complaints, headaches are very, very common for this kinds of, for the pediatric population. Adults, usually it's low back pain and arthritis, especially in the geriatric population. The issue is this healthcare costs. Again, this was mentioned earlier, and if you look at this amount here per person per year, kind of gives us a little bit of a clearer perspective. 4,500 is how much we're spending per person per year in terms of healthcare costs. And this is in relation to direct healthcare costs, like medications, treatments, surgery, interventions, those kinds of things, as well as lost productivity, lost work. So it's really huge, to the point that if you add all of this up, it's almost equal to the healthcare costs that we spend for cancer, diabetes, and heart disease. And the prevalence of chronic pain is also such that if you combine the prevalence of patients who are affected with heart disease, cancer, and diabetes, that's pretty much the amount also, about 126 million of people who are afflicted with chronic pain. So it's a huge number. So what do we have then to try to help with this, or to try to help guide our providers? We do have chronic pain guidelines, and there's quite a bit of them. The problem sometimes, the IOM, for example, has stated that providers unfortunately have a hard time instituting, or they don't always use the guidelines in their patient care. A systematic review, which actually just came out this year, 2017, talked about the different barriers and facilitators into the uptake of guidelines. And a lot of it is time constraints and insurance issues. And those are huge things that prevents providers from actually using these guidelines in their care. But we have a lot of them. So the ICSI, University of Michigan Health Systems, American Society of Anesthesiologists, there are even different guidelines for different kinds of pain. You have for low back pain, for headaches. You have the American College of Rheumatology guidelines for fibromyalgia, for OA, for RA, those kinds of things. So there's quite a bit out there. The problem is whether we use these guidelines. And so what we're going to talk about is to try to see how we can incorporate some of these guidelines in a practical way when we start seeing patients, or when you start going out in your practice very soon, or for those who are currently in practice. Because it's very clear that as nurse practitioners, we have a huge role here. With that high prevalence and the high healthcare costs, it's estimated that about 33,000 pain patients are allotted to only one pain specialist, which is a very, that's very, very difficult. So if nurse practitioners then come in and be more active in terms of pain management, that would help our healthcare in terms of pain, or chronic pain anyway. So we're talking, again, mostly about non-malignant chronic pain in here. So let's start with the preclinic processes. Guidelines, this is a missed opportunity. Guidelines don't talk so much about preclinic processes. For those who have already been in practice, how many times have you gotten into a position where you see a patient, they're already right in front of you, it's a new patient, and then they tell you they're on fentanyl 100 microgram patches every 3 days, plus Percocet 6 times a day, and then sometimes even adds morphine to the mix. And then you're sitting there thinking, how did I get myself into the situation? What am I going to do? This patient doesn't have insurance, or this patient probably has an HMO. It'll take me about 3 months to get them to a pain specialist. So it gets us in a position to where we're stuck within the primary care. So preclinic processes talks about really having some form of systematic process to make sure that we screen our patients before we actually take them in. So for example, what we've done is we have a template, and we've trained our MAs, our office staff, and patients who are coming in with pain, whether they're new patients or follow-up, if they're coming in with pain, they're trained to ask, are you on pain medications? How much, how often? Make sure you bring your pain medications with you, the actual bottles, the most recent prescriptions. Bring your medical records. Those are very, very important. And the idea is not that we want to grill them beforehand, but we want to make sure that when they're in the clinic, that they're not wasting their time, that we're able to manage them very well. So that if it's a case to where we're not able to help them within the primary care area, then we're able to give them referrals already at that point, and send them to other providers who might be able to address their pain management better. So it allows for access to care even if we haven't quite seen them yet. But it prevents us from being in the spot where we have to take care of this patient, and then forces us to refill medications that we don't want to, even with the high degree that they're at. Or it prevents those confrontations with patients when you have to say, well, I can't write that much. It's, this is my first time seeing you. I don't know you. I don't have an established care with you. So that's really what's important in terms of preclinic processes. The role of the clinic staff when they're very well trained, and then make sure that they give reminders to these patients, tell them to bring those copies of records or bottles of prescriptions, things like that, so that it helps facilitate safe, effective, and efficacious care once they're actually in your clinic. And if they're not anybody that you can manage, based on your strengths and your capabilities, then you're able to give them referrals or send them out to wherever they need to be, as opposed to being stuck with their care. So that's the importance of the preclinic processes. So then now you have your patient in, so now you do your history and exam. I really like this mnemonic. I don't know if you guys use that, old cards. I really like this. I always enforce this to my students, not just about pain. Any kind of chief complaint they come in, try to see if you can get the onset, location, duration, all of that, because that makes a difference when you're doing your differentials, when you're coming up with working diagnoses so that you can better treat the patient appropriately. What are the associated factors? Make sure that you do the MS and neuro exams, but at the same time, again, don't focus in so much on just the musculoskeletal neuro process. There are other areas and systems in the body that can potentially cause that pain. I remember when I was still new in practice, I had a patient come in with mid-back pain, thoracic pain. And it's a new patient, so I was excited. I did the workup. I saw the patient. I presented it to my collaborative physician, because we still had collaborating practice back then. And then he said, well, what are your differentials? Because I was really just honing in into just back pain, just muscular, nothing much else. Then I realized that the patient's blood pressure is actually high. We have a differential there about potentially thoracic aortic aneurysm, which is probably rare, but what if there is that kind of situation? Those kinds of things can happen anytime, and it only takes one, and then you're done. So you want to make sure that we don't always, take these things for granted when we're doing our differentials and our diagnoses. And then we have a lot of screening tools and standardized tools that we can use that's available for us. The patient health questionnaire, evaluating mental health, that's always important. Do they have any history of substance abuse? If you're going to start them on opioids, are there any risks to this? Have there been any history of aberrant behaviors? You want to make sure that you get all of this information and then document them very well. You come up with then the joint goals, and we'll talk about those in just a little bit more. But one of the things that we try to, one of the predictors of chronicity is lack of employment. So when patients come in and they say they don't have a job because of the pain, unfortunately, these are the patients where the disability is greater, the chronicity is longer, and it's harder to get these patients back towards employment. So these are the ones where our healthcare costs are going to definitely increase, and chronic pain is going to be very difficult to manage. So these are the things that we really want to keep an eye on when we're doing our history and exam. Okay, here's the case scenario. Now that you've done your history and exam, you've got a patient who requests an x-ray for his low back pain. Which of the following is not true? Osteogenic formation in the intervertebral disc is predictive of discogenic disease. There's little justification of extensive use of x-rays in low back pain. There's poor relationship between most radiographic abnormalities and symptoms of low back pain. There's low yield of findings on plain x-rays that alter the management of low back pain. Which of this is not true? What do you think? Be brave, it's okay. It's not an exam. The first one, yeah, exactly. So all three pretty much are, all the second, third, and fourth, they're pretty much saying the same thing. Unless there's neuro deficits, then it is a good idea for us to go ahead and do some diagnostics. What we're trying to avoid here is healthcare costs, increasing healthcare costs that doesn't really impact treatment. Because whether an x-ray shows degenerative disease or it just shows lordosis or spasms, we're still going to treat that patient with their pain, right? However, when they start having some neurologic deficits, then we know that there's something that we need to do further, whether we need to do an MRI or whatever other treatments that we need to do for these patients, as well as referrals, especially if we're within the primary care. But it's one of the things, one of the guidelines, not one of the guidelines, one of the thematic similarities among guidelines is about being very careful with ordering diagnostics all the time when they're not necessary. It has its place and time. One of the issues also with us ordering so many diagnostics is that patients start feeling like you're having to look for the cause of the pain. And at some point that has to stop unless there's a new pain or an acute pain that happens, right? So sometimes when it's a new area of pain or a new discomfort, it's not unusual for us to probably try to figure out what's causing it. And then at some point when they've developed chronicity, it's years down the line, there hasn't really been anything changing. There is really not a huge justification for us to continue doing diagnostics at this point. It's all about management from here on, unless there are new indications for it that you can justify for these patients, like neurological deficits, for example, or new types of pain over and above what they have at that point. Okay, so now let's talk about management. So you've got the patient, you've done your history and exam, you've done your diagnostics if they need it. What are the management things that we're talking about? So we have the pharmacologic, you have your non-pharmacologic. Either way, a lot of this is really about interdisciplinary management. It's not just you as the primary care provider here. You may be the gatekeeper. You may be the first person they come to. The next step then would be to try to make sure that you refer this patient also to appropriate providers. Counseling, do they need that? Pain management, do they need that? Physical therapy, do they even need neural or ortho spine? You know, all of those kinds of things. Those are really very important. I meant to talk about, oh yeah, so one of the, you know, when you're looking at management, one of the things to think about is the goals again, right? So it's about joint collaborative goals. We talked about earlier as one of the goals is not just about reducing the pain, which is really difficult, but also trying to get these patients back towards employment, or at least to some gainfully type of quality of life that they might have and functional capabilities. Because without that functional capability, then it's really hard for them to kind of get back to work or do their ADLs or housework and all of that stuff. So as we decide this management and refer them for interdisciplinary care, we want to make sure that we pay attention to those joint goals that we have with our patients. And we have to keep those realistic as well. I think it's been stressed earlier about there's no such thing as pain-free. Pain will come back every now and then. A lot of this really entails communication with a patient. And it's easy for us to say that sometimes when you have a 15-minute visit with a patient, sometimes it's easier for providers then to give a prescription. That's the problem. However, sitting down with a patient to explain these things to them and making them realize that it's hard to be pain-free, pain can come back and forth. Part of management is self-management as well as self-management support from the providers, and making sure that the patient is doing what they're supposed to be doing in terms of either pharmacologic or non-pharmacologic orders that we've given for them. So those are very important to talk about. So when we talk about pharmacologic management, we have our prescription and over-the-counter. We'll talk about opioids in just a second. We have a lot of adjuvant medications that we can use other than just opioids. Regardless of what we do, managing side effects and drug interactions are very important, because in primary care, it's not unusual that the patient coming to you with a complaint of pain also has diabetes, hypertension, COPD, history of stroke, you know, all of these things. Lots of comorbidities. It's not very common that you have a patient where they're coming into you just for the pain, maybe a few, but for the most part, when you're in a heavy practice, a lot of these patients have several comorbidities. So we want to make sure that you look not just for the side effects of the medications, but the drug interactions. Rational polypharmacy is important. So the guidelines talk about, and there's a lot of discussions here. The guidelines talk about if the anticipation for that pain is short-term, then short-acting pain medications are appropriate. However, there's also a time when that pain is probably progressing too long and you're not able to manage it, that it's a better idea then to switch this patient to a long-term or long-acting pain medication and then use a short-acting medication for breakthrough. As far as when to transition from the short-acting to long-acting, the guidelines are not clear about that. And so a lot of it is really about judgment call and making sure that you document your rationale for why you're doing what you're doing. Calculating morphine milligram equivalent, that's also very important, especially because the guidelines now, CDC, for example, talks about MMEs a lot. So within the primary care, if you've calculated that your patients are taking about 90 morphine milligram equivalents of medication, you're probably best to send that out to pain specialty already. they stress that, especially because just at 50 MME, there is twice the likelihood of overdosing versus those who are only at 20 morphine milligram equivalents. And we have a case study for calculating MMEs later on down the line. But this is very important consideration when we're doing pharmacologic management, especially in relation to opioids. And same thing with equianalgesic dosing and conversion. It's not unusual that sometimes patients develop tolerance on opioids. Sometimes you might have to switch them to different opioids because of tolerance or because of insurance issues. They have cost prohibitive medications that they're not able to continue anymore. So now you have to switch them to something else. Or you have to go from short acting to long acting, or you start weaning them, for example. So equianalgesic dosing and conversions really important. And we'll do a case about that in just a sec. All right, medication management. So earlier you had a really good information and slide about the nociceptive pain, neuropathic pain, and then central sensitization. So these kinds of pain mechanisms are important to remember because it makes a difference in terms of what analgesic medication you're going to choose for your patients. So for example, your anti-inflammatories and acetaminophen, these are still very, very highly recommended for patients with purely nociceptive pain or who have at least a mix of nociceptive pain in their pain trajectory experiences. Muscle relaxants, very, very common. Again, they're not meant for long-term use. Usually spasms are acute, and so it's not something that we commonly use for long-term. Nevada, for example, we're so known for what we call our pain cocktail, which is a combination of hydrocodone and soma. I don't know how you guys are here, but that's one of the issues there in Nevada right now. Here's Lortab, and then here's soma. So it's a combination of an opioid and then a muscle relaxant. Again, all of these problems, because with the combined effect, it maximizes the effect of relief perhaps for that moment, but it also increases OD potential, addiction, diversion, those kinds of issues. Antidepressants. So for a lot of our patients, it may not necessarily be because of this stigma about depression, unfortunately, and pain in itself. But because of all this stigma, they think, well, I don't need to be an antidepressant. Well, the issue with a lot of our antidepressants are SNRIs, especially. The great use for SNRIs that we're really pushing nowadays is they're very, very helpful for central sensitization. So if you recall, central sensitization is that when you have repeated constant pain stimulus in the peripheries, eventually you start getting changes within the structure of the brain, and they've seen this in actual MRIs and imaging, right? And so what they have said is when you start putting them on SNRIs, these medications block the reuptake of your important neurotransmitters, the serotonin and norepinephrine, which means more of them stay within the synapse. And so when there's more of that medication, or when there's more of that neurotransmitters in there, it doesn't just elevate the mood, but actually helps with this central sensitization syndrome that patients have. And so that's that's a huge indication for these types of antidepressants. And then we also have your anticonvulsants or your sodium channel blocking agents, or huge use in terms of neuropathic pains. What's a good example of an anticonvulsant, for example, that we use for neuropathic pain? What's that? Gabapentin, Lyrica even for fibromyalgia, huge indication for that one. Sodium channel blocking and oral antiarrhythmic agents. I don't know if they use that here in Connecticut. Lidocaine is something that we use in Nevada. And in California, they do even IV infusion of lidocaine sometimes with monitoring. And the idea is to help stabilize the neuronal membrane because of that premature rapid firing in neuropathic pain. The use of anticonvulsants and sodium channel blocking agents are very, very helpful. And then we have your topical pain relievers, of course, transdermal medications, lidoderm patches. Those are really, really helpful. Compounded medications. This is something that's big here in Connecticut? Not really. So this is something that is not under the FDA rule. It's under United States Pharmacopoeia. So what they do is they use FDA substances, FDA-approved substances, and in approved facilities, and you want to make sure that if you're using this, it has to be a facility that's really been approved. They've been certified, their sterilization processes, the compounding of the medications are done in best practices and best processes. So the idea for compounded medications is they use small amounts and percentages of medications, mix them up, and then use it either topically, which is the main entry point for this one. So for example, they might use a little bit of an anti-inflammatory, like Toradol, for example, ketoprofen. They might use a little bit of an antidepressant, like Elavil. They'll put a little bit of a sodium channel blocking agent in there, like lidocaine, mix that all together, even a little bit of anticonvulsant. Mix that all together, and for a lot of patients, it really actually does help with the pain too. So that's something that we're seeing a lot more common in various practices, especially with all of these opioid issues that we're having, and providers being very, very cautious about writing opioids. All right, here's another case. 32-year-old male patient, neck pain for 3 months, works as a baggage handler. No known trauma or injury other than MVA about 10 years ago, and he recovered from it without any problems. He is overweight, history of hypertension, is on blood pressure medications, pain 7, 8 out of 10 at its worst, achy in the neck, it's non-radiating, has been managing with heat and ice as well as over-the-counter ibuprofen and acetaminophen, has done some chiropractic treatments, said it doesn't help, now feeling fatigued and tired, and that's primarily why he came. Usually some of these patients tolerate pain very well until they get really tired and fatigued, and so they come. X-ray showed mild degenerative disc disease with cervical facet arthropathy. So facets are the joints in the spine, and so there's some arthritis within those joint areas. And a lot of these, the way this patient presents with no radiation doesn't look like there's a disc involvement, so it's likely, other than degeneration though, there's no herniation with the radiation, so it's primarily mechanical in terms of its pathology. So what would you do for this patient? Patient standing a lot, lifting a lot, high BMI, history of high blood pressure. Would you change the NSAID? So this patient is on over-the-counter ibuprofen, acetaminophen. It's probably, you can, depending on the case situation. What you worry about for NSAIDs, for example, is if they have a history of hypertension, then you worry about managing the blood pressure other than managing the pain. Patients have history of renal issues. Patient has history of GI, toxic effects from NSAIDs. You want to kind of put all of this consideration when you're thinking about NSAID, whether you're decreasing it, changing it, or stopping it, whatever you want to do. Prescribe an SRI, that's possible. The patient has symptoms of fatigue and issues in terms of sleep. If you screen this patient and do depression screening, it's very likely that that patient will score high. And so it's a good indication for an SSRI at this point. SNRI is a possibility, but the case doesn't really talk so much about any kind of central sensitization issues yet. The patient has only had it for 3 months, so maybe not, maybe something in your arsenal later on down the line, but hopefully it doesn't get to that point. Hopefully it doesn't get to that central sensitization issue. Opioids, probably too soon. Prescribing an anticonvulsant, probably not. There's no neuropathic pain components just yet. It's all mechanical, eggshell pain. Adding a tricyclic depressant, that's possible. You either do that or SSRI. And you don't really want to no change. You do want to do something for this patient because that's why they went to you. And physical therapy, referring this patient to physical therapy would make sense at this point. Okay, so Teresa had a slide similar to this earlier. It's not presented as a table, but this is a really, really good one to look at, or the one that you have from earlier. It separates out your nociceptive and neuropathic pain. So under your nociceptive pain, you have your non-inflammatory types of pain like osteoarthritis, for example, and then inflammatory like rheumatoid arthritis. Peripheral pain, you have your examples earlier, for example, diabetic neuropathy, central pain, fibromyalgia, for example. So if you look at opioids, there's really no indication for opioids in central sensitization, yet this is where we see a lot of our patients getting opioids. What normally happens is you have patients with initially nociceptive types of pain, maybe even peripheral pain, just diabetic neuropathy, for example, and then they because of that, again, repeated stimulus and firing and consistent and persistent pain. It's not unusual that they then develop central sensitization issues where central neuropathic pain then happens. At this point, there's not a huge indication for opioids. So if you see down here, you have your novel SNRIs that are really, really important. For neuropathic pain in general, you have your antidepressants like TCAs or SSRIs, and definitely your novel SNRIs like venlafaxine, Cymbalta. Those kinds are really, really good and very helpful for these patients. And when we explain this to them, because sometimes they look at it and they think, oh, but I'm not depressed. Why am I being put on an antidepressant, for example? When we're able to sit down and explain their rationale, a lot of times it helps them to kind of understand why we're doing what we're doing. Because I've seen it happen so many times where we start these and we don't tell them what we're doing. They don't take it because they don't think it's necessary, it's important. They only take the opioid. And remember, what we had said is once they get to that central sensitization issue, opioids are really, really not indicated. They're just definitely not helpful. All right, so in terms of statistics then in relation to opioids, I think we had a discussion on this earlier with Teresa. So data right now says that with the amount of medications, opioid medications that we are prescribing to adults, you can pretty much supply every adult in the United States with a 30-month supply of a pain medication, a whole bottle, or 1 month bottle of medication of opioids. That's how much we are actually writing. So it's something that we have to remember when you all start going out in practice, or those who are already in practice. That's something that's very important. And it's a huge issue because as we increase our prescription, we also increase that OD, opioid overdose or substance use related deaths due to opioid use. Another statistic that's probably important is globally, the United States consumes about 80% of the world supply of opioids. And that's huge. 80% is just one country. It's not even a continent. Yet we consume 80% of that. The 20% is everybody else in the world. And that's how much we have gotten. That's how big this problem has become. So this is an old data, 91 Americans. This is in 2015. I think Teresa gave an updated one in 2015. Another updated one in 2017. There's an average of 115 opioid overdose deaths now, 2017 per day. So even despite all those medication-assisted treatments, as well as naloxone kits that are being recommended, we are still having these issues. And we'll talk about those medication-assisted treatments in just a little bit. This healthcare cost obviously is really, really high in relation to these. So what do? We have these guidelines, the VADOD, something that you have right now in your folders. ASIPP is another agency or another organization, CDC, American Academy of Pain Management, American Pain Society. All of these are guidelines that are available out there. Again, whether we're using these guidelines is the issue. Methadone, for example, also has its own guidelines because it's just a specialized opioid or specialized pain medication that we use. But there's also Canadian opioid guidelines. There are guidelines internationally that's available. It's all out there for us. It's just a matter of us being able to use it in our practice. So the CDC, for example, came up with their recommendations a couple years ago or so, and this became a huge discussion among organizations because they felt that CDC is being a bit prescriptive and that they are going into the realm of providers, and providers are not now having, or we don't have that independence to make our decisions to individualize patient care. Because the CDC recommendations do make sense by talking about, start slow, keep it low as much as you possibly can. And if you're starting, because they think that if you're starting new pain medications, usually 3 days is what they recommend, maybe not even more than 7 days. And that's where a lot of our pain organizations have come up to say, let's not be too prescriptive. This is too tight. This is too hard to manage. The bottom line for the CDC recommendation is about initiating short-term use of opioids and a therapeutic trial of it, meaning we start these pain medications and tell our patients, this is a trial. Let's see if it works for you. If the benefits are there and we can definitely document it and it's helping, then so be it. But if they're not helping and we're continuing to escalate the medication up and up and up, then we need to do something else and we have to start weaning you from it. And so these kinds of discussions will not work when the patients are already on these pain medications. They work better when you introduce to them at the very, very beginning, and that's where we're having a hard time. So tell our patients already that this is not something that they will likely be on forever unless it truly does help and there are no side effects or adverse reactions that they're seeing. So again, we talked about short and long-acting opioids earlier, using short-acting opioids first for initial treatment. And if it works, then that's fine. But if we're seeing that these patients are needing pain medications in a chronic basis or long-term basis, then switching them to long-acting pain medications would be helpful. And then using a short-acting medication in between that for breakthrough pain would be good. So here are your examples of your short-acting and long-acting. Methadone is a different story. This is a medication to where if you're new in pain management, especially within primary care, it really involves a lot of pain experience to be using this. Methadone has a very, very long half-life, and it can potentially cause fatal arrhythmia, cardiac arrhythmia. So if you have methadone clinics in town, or if you have pain specialists and this patient is on methadone already, it's best to have them manage those as opposed to doing it in primary care. It's a really good medication though. It's been around for a while. If you have the experience for it, it's very good medication because you're able to help these patients. The methadone is a really good medication that helps with pain, but also helps limit the abuse potential and tolerance potential that typical opioids do. So that's the great advantage for methadone. But it's also a more difficult medication to manage, and it takes a reliable patient to work with for you to be able to really have a good management in the area of methadone. Opioid resources. CDC has a free app for the MME. So now let's talk about morphine milligram equivalents. So they have a really good app for, and actually CDC has an app for their whole guideline, and it's free to download. And what's really helpful is this calculator for calculating your morphine milligram equivalent. So you don't have to do it by hand. It's easy to do it by hand if you've been doing it. But if you use the calculator, it's right there. It's very helpful. But these are really good resources. So how do you do conversion? So the way to read this is morphine, just something to always remember. So morphine is on its own, right? So if your patient is on 30 milligrams morphine, that's 30 MME. That makes sense, right down here, morphine. Let's look at oxycodone, just an example for these conversion factors. So for example, if you have a patient on 10 milligrams oxycodone, conversion factor is 1.5. So 10 times 1.5, this patient is taking 15 milligrams MME. So that's pretty much how you can calculate the morphine milligram equivalent. And again, remember that that's important because when you're managing patients in primary care and you're getting up to the 50, you really want to have very good justification in your chart as to why you have that patient in that much medication. And CDC guidelines even encourage that you probably should prescribe now this patient or tell the patient about having naloxone available easily, whether through his family or with them, in case something happens. And then obviously if you get to that 90, you know that that patient should be out to pain specialty already. They try to discourage primary care providers managing patients at that dose for chronic non-malignant pain. So let's just get a case. Patient has Percocet 10-325, 1 to 2 tabs every 4 to 6 hours. She presents to your clinic. She stated she's taking 2 tabs every 4 hours. So first of all, I take issue with how this prescription was written. 1 to 2 tabs every 4 to 6 hours. So the patients read this and they're going to feel it's okay to take the max. So I would do 2 tabs every 4 hours. And certainly this patient's doing that. So now the problem with that is 2 tabs every 4 hours. That's 12 tablets, right, per day. If you calculate that 12 times Percocet 10, the oxycodone content, that's 120 milligrams oxycodone. And even worse, calculate 12 times 325, it's 3,900. I calculated that earlier already. So it's 3,900. So you're already to that max of acetaminophen. And if this patient is going to be on this kind of medication for a long period of time, his liver or her liver is going to get shot eventually. So we have to be very, very careful here. What I usually recommend, what we do in our practice, is we say 1 tab every 6 hours and then just keep it there. Less is better if we possibly can. But patients with chronic pain, you would want to try to minimize that as much as you can. So, and be more specific in writing that prescription, because then they would think it's okay because of how you wrote it. It's okay to do the 2 tabs every 4 hours. All right, so what is the morphine milligram equivalence per day on this? Remember, this is oxycodone 10, conversion factor is 1.5. So how much MME is that one? Excuse me, 120. 120. Remember, she's 2 tabs every 4 hours. That's 6 or what did we say, 12 tablets? So 12 tablets times 10 milligrams, so that's 120 milligrams. So how much MME is 120 milligrams of oxycodone? 180, because that's times 1.5. So 180 MME. Then what you want to do is you decide to convert her to MS content. When you do conversion, that's where this equianalgesic conversion comes in. Before we talk about equianalgesia, let's talk briefly about tolerance. It's not unusual that as patients are on pain medications, opioids particularly, their opioid receptors become so down-regulated that they start tolerating the medication, meaning the analgesic effect is not the same as how it was before already. So it's a physiologic process. It's something that normally happens to the body. Can't really blame. It's just there. It's tolerance. Cross tolerance is when you switch a patient from one opioid medication to another opioid medication that has similar properties. These patients develop cross tolerance, meaning because of that similarity in the properties of the opioids, it's not unusual that whatever you switched him or her to, he or she will also develop tolerance to that medication. So that's the unfortunate situation when you're switching medications. Luckily, in terms of opioids, what happens with opioids is there is incomplete cross tolerance. And this is related to various pharmacokinetics, just individual differences in how we metabolize our medications, our genetics, how our liver is functioning, our other comorbidities, those kinds of things. So incomplete cross tolerance then would mean that even if you switch somebody from one medication to another opioid medication with similar properties, you may not necessarily get all of that tolerance situation happening. And that's why when you do equianalgesic dosing, they recommend for you to do 50 to 67%, which means reducing that MME by about 50 to 67%, and then starting that patient on that new medication, and then titrating it up or down, depending on how you're doing. So again, for this patient, for example, we said he is taking, or the patient is taking 180 milligrams MME, right? So if we're gonna switch her to MS content right here, about 50% would be about 90 milligrams of morphine. So you want to be a little bit more on the conservative side if you do, and it's easier when you're calculating anyway. So 50% of 180 if you're doing equianalgesic dosing is 90 milligrams. So if you're going to switch that patient, then you're going to put that patient on a total of 90 milligrams of morphine per day. So MS content, for example, is available in 30, 60, and 100. It's not available in 90. I think the newer ones, Avinza, for example, or Cadian, may be available in that formulation. So if your patient is one that's Medicaid, Medicare, or insurance is issues, MS Contin is usually cheaper. So you might decide to have the patient on either the 100 or the 60 milligrams, depending on how you want to individualize that care, and then titrate that up or down depending. Okay, so that's how MME calculations and equianalgesic conversion happens. Another issue that's important to consider is the cytochrome P450. These are enzymes in the liver that are responsible for detoxification and metabolism of our medications. And these are important especially for opioids, because some of our opioid medications, fentanyl is a very common one, goes through this P450, cytochrome P450. We have CYP inhibitors and CYP inducers. So what happens if you have a patient on this medications, on CYP inhibitor medications, and you put that opioid together with that, what happens is, because of that metabolism and detoxification that happens, the opioid medication ends up in a greater amount of quantity within the bloodstream. There's less plasma clearance going out, meaning then there's more within the blood. And so we have to remember that then that becomes an issue, because if we have medications, let's say an antiarrhythmic or a macrolide, and then we have a patient on antibiotics, we're going to expect that the effect of that opioids is going to be higher. And so we need to worry about that because of the potential for overdose. So the opposite is true for medications that are CYP inducers. What happens is that the plasma clearance of the medications are fast, to where they feel like they are not getting the same relief that they were getting anymore with this medication, from the opioid medication. And these are the patients where they might come in and say, it's not helping, and then we start thinking, well, it's probably something else going on here. But if we do some further investigation on their medications, we realize that we actually have two medications that are CYP inducers for this patient. So we have to be very, very aware of that as well. Because it's easy to pass judgment right away, right? We think, well, maybe she's diverting or whatever it is that she's doing, and then we realize it's actually a physiologic process that we need to address. Here's an actual case scenario that happened. You have a chronic pain patient with history of heart disease. She has been on 50 mics of fentanyl patches every 3 days and developed ventricular arrhythmias, and so she was put on amiodarone. So again, amiodarone is a CYP inhibitor. So the patient became sedated with profound bradycardia and hypotension. Well, what happened was the immediate conclusion that the providers had thought was, well, maybe the arrhythmia is getting worse. There's decreased cerebral perfusion, and that's what's causing this bradycardia and hypotension. When they increased the amiodarone doses, it actually became worse instead of getting better. And then when they did it the other way around, where they addressed the pain medication issue, they decreased the fentanyl to 25 mics, and the patient actually started to respond better. Because remember, amiodarone is a CYP inhibitor. And so that prevents the metabolism or detoxification of fentanyl and the plasma clearance out of the body. Instead, it allows the fentanyl to stay in the bloodstream longer, and hence that was actually what was causing this hypotension and sedation for this patient. She was starting to get OD. Okay. So those are just important considerations that we have to remember when we're seeing these patients. It's not as simple and easy as just writing prescriptions. There's a lot more that's involved to it. And then we have this medication-assisted treatments, and these are usually our other opioid agents. Opioids usually, the way they work is by addressing the mu and the kappa receptors. These are the opioid receptors. So both the mu and the kappa receptors are those that help with analgesia, but they're also the ones that impact respiratory sedation, that can cause constipation, those kinds of things. So opioid mixed agonist, antagonist, and opioid antagonists, these are different kinds of medication-assisted treatment that are, well, particularly mixed agonists and antagonists. The way they work is they either help or they balance the mu and the kappa effect, or they help more with the kappa or more with the mu, either one. So very common, somebody asked about buprenorphine earlier. The advantage of buprenorphine is it has a ceiling effect. So usually it's 4 to 24 milligrams. So anything that has a ceiling effect then, whether you take more of it, let's say you're taking more than 24 milligrams, which is beyond what's indicated, it doesn't really help with the pain. And so there's less potential for abuse. And that's something that we reinforce to providers so that they'd be a little bit more comfortable in using this medication. However, prescribers, when using this medication, they do want to be trained. There isn't that waiver anymore that Teresa talked about, but there's a training that you want to make sure that you're aware of when using this one. So the Congress, before, it was only prescribed by physicians prior to July 2016, somewhere around there. But after that, the Congress passed a bill for NPs and PAs to be able to prescribe buprenorphine. And then you want to also look at your state regulations and guidelines in terms of any kind of training that they need for you to do that. But that's a really good advantage for buprenorphine, is it has the ceiling effect. A really good combination is this buprenorphine naloxone, which is Suboxone. I think somebody mentioned this earlier as well. So again, you have your buprenorphine with that ceiling effect, and then you have the naloxone, which is an opioid antagonist. So the way this works is usually it's a sublingual medication. So it allows for that medication to get absorbed well. When the patients crush it, the problem is the naloxone, which is the opioid antagonist effect, becomes activated. So it prevents misuse of that medication. And so it's not going to work, because then obviously you are using the buprenorphine for pain, but if you started crushing it to try to see if you can get a little bit more of a high in it, the naloxone component of it actually gets activated and then antagonizes that opioid agonist effect of the buprenorphine. And so that's how this medication is structured. If you swallow it, it goes through that first pass metabolism. So the metabolism of the medication is not great. And so the absorption is not something that is going to help that patient very well. So it's really a good medication for dissolving in the buccal mucosa or sublingual. And that's how this one works very well. Let's talk about the opioid antagonists. Are they strong, or do you have, you've heard about the naloxone kits and things like that here, or nationally, right? Do they have that here in your pharmacies now too? CVS, Walgreens, those kinds of things. So it's not anymore, we don't have to prescribe it. You can if you want to, but definitely if you have a patient in primary care who's at least on 50 MME, you want to be able to document in your treatment plan that you have talked to this patient about having a naloxone kit available, which is a little bit, I guess you get into this ethical discussion in your mind thinking, okay, here's your pain medication patient, and just in case you OD, here's your naloxone. And hopefully somebody's there to help you at that time. That kind of thing. So it's really hard. But what the government is saying, or nationally what they're saying, is hopefully it will decrease this opioid overdose. Well, we looked at the numbers earlier, from 91 opioid overdose deaths in 2013 to about 100 in 2015, and then now about 125 in 20. It's still going up. I don't know, maybe we will see a decrease this year and next year. It's hard to tell. Maybe we're not utilizing that naloxone kits just yet. But it's available. And pharmacists can also, when they give you your prescriptions, or they give patients the prescriptions for opioids, if they've calculated that these patients are on this much, then they can go ahead and give that patient naloxone kits as well. So it's definitely very available out there. Okay, so risk mitigating strategy. So we talked about what are the things that we need to do in our practice if we're going to be managing patients with chronic pain. So we talked about preclinic processes earlier, and we'll talk about these other things as well. Important thing again is to make sure that your staff is trained, Make sure that you have standardized tools that you're using. You're going to be using forms that are beyond the typical primary care forms and tools. SOAPP, for example, ORT, opioid risk reduction tools, brief pain inventory. These kinds of standard tools are not something that we typically use in primary care, but if you're seeing pain patients, you want to make sure that you set up your EMR or however you're documenting your patient care so that you are well covered in ensuring that you have all the guidelines done when managing these kinds of patients. And it's not meant to scare us, it's meant to protect us as well in our practice, just in case something does happen, and hopefully protect the patient as well. And one important thing is consistency within providers in the clinic, because you may very well be doing what the guidelines are saying, but if you don't have policies and procedures and guidelines within your clinic that every provider should be following, it becomes really difficult. So you want to make sure that there's consensus among the providers in the clinic so that you don't get stuck with covering another patient's provider who ends up being on so much pain medications more than you like to write. And that does happen sometimes. They're out sick or they're on vacation. Now you have to see that patient. Now you have to write this medication and everything else. So it becomes very difficult. Consistency is the key. Staying updated with federal and state guidelines, those are also important. For example, in Nevada, I don't know how it is here, as of January 1, on our pain prescriptions now, we need to write the diagnosis, the ICD-10, the diagnosis code. We need to write how many days it's good for. So, for example, usually we say, let's say, Percocet 1 every 6 hours PR in pain, number 30. Usually that's all. But now they want us to write the ICD for what we're using that pain medication for, and how many days that medication is good for. So Percocet 1 every 6 hours PRN pain times 30 days, number 30. So what that's saying to the patient and the pharmacist is, just because you wrote it for every 6 hours PRN pain, hopefully you're not using it every 6 hours round the clock all the time because you only have 30 pills for 30 days, right? And that reinforces the idea of the PRN. But that also then sometimes gets patients to a status where they may be undertreated. So you have to be able to balance that very well. But that's the state guidelines that we are now having to do. Other than making sure that we have records for these patients, established records, which is always difficult to have. You have new patients coming into your practice and they want this and that, and then you don't have anything to go by. Now, within our state, with anything, we usually want records anyway. That's a given. But the problem is you don't always have that available. They're enforcing that in our state now. And it does put the provider and the patient in a difficult situation because a lot of times these new patients don't come in with their own records. But it also puts the onus on our patients to be more responsible in their care, in self-managing, so that they take part in that pain management process. Okay, here's an example of informed consent. If you don't have this in your practice, the NP Journal article has this one. The guidelines also have examples of these. The idea for informed consent is it gives you the benefits, risks, side effects, and exit strategy. Exit strategy is important, meaning here's your pain medication, opioid medication. You are consenting to using this, and you agree to it because there's no other alternatives right now, or the other alternatives are not enough. But it's a trial, meaning if it doesn't work or the risk exceeds the benefits, then we're going to start weaning it down. So that's pretty much what the patient is consenting to when you have an opioid-informed consent. On the other hand, you have an opioid agreement also, so you really want to make sure you have these two forms available and signed by your patients. Opioid agreement then is, what are your responsibilities as the patient when I give you this opioid medications, and what are my responsibilities as the provider? So their responsibilities may be to make sure that they're not doing any doctor shopping, there's no diversion, they are okay to submitting to pill counts, to submitting to random urine tox screens, those kinds of things. Importantly, make sure that these are, really readable. It's something that patients can understand. We usually review this and sit with patients every year so that we can make sure that they remember it. And sometimes you can pull it out even sooner than that if you're having some patients with aberrant behaviors before you discharge them from your care. That does happen sometimes. You might end up having to discharge them if you're starting to use opioids in primary care and they're not doing what they're supposed to be doing based on your agreement. PDMP is another risk mitigating strategy, your prescription drug monitoring program. So all 50 states, all of the states in the US have operationalizing or have PDMPs that work very well. The extent to how this works is the difference. So Nevada, for example, I'm not sure here in Connecticut, but Nevada, we're able to access patient's name, how much of pain medications they're using, which pharmacies they went to, what the name of that medication they got that was dispensed to them, how many pain medication was used, all of this information. So we're able to see all of that. And in addition, in many states, as a provider, you can also go in and maybe every month, every 3 months, every 6 months, depending on how often you're prescribing pain medication, you can go in, put your name down, put the dates, and then see the names of patients you've prescribed opioid medications or controlled substance to, not just opioids, controlled substances too. And you can kind of scroll into this to make sure that there's not anything that seems odd. When I just started my practice, we had a situation to where, you know how your DA numbers and your NPI numbers, those are out there. It's available for patients to use. And when you have patients who have researched very well, they're very good in terms of the healthcare system, well, this is what happened to us where this patient, because I was in pain practice, specialty practice, and started using my name and started prescribing himself 180 of oxycodone on top of morphine. And so luckily it is a pharmacy that we use all the time, or it's the location of that pharmacy is where most of our patients go to. So that pharmacist who happened to be there is somebody who's familiar with our prescribing practices. So we were lucky that she called and asked, well, can you verify this prescription that we just received? And sure enough, it's obviously a fake one, right? And so that's something that we have to be very, very careful about. Because it can happen all the time. And so what we did was we actually blocked that. There's a way of communicating with your pharmacy so that they can actually have this note in your record to say any prescription written by this provider needs to be verified. It's additional work for them, but you can do that. And it's not 100% that they're going to do that all the time, because sometimes a lot of these pop-ups, not everybody looks at it. But hopefully you have a good pharmacist there and they're gonna watch those kinds of things. But if we didn't have a good relationship with that pharmacist, they probably will think, just fill it in. You know, nowadays though, with all of these opioid issues, people are a lot careful. They're a lot more cautious in this regard. So hopefully those things don't happen as often anymore. Urine drug testing is another risk mitigation. So depending on the assay you use, you have the 12 panel, you have the 5 panel, or you have the 10 panel. If you're not very sure in terms of the results, you can send it into laboratory for confirmatory testing. You have to be very cautious in interpreting this. So, because for example, there's some medications, morphine, for example, is a metabolite of codeine, and what's a common street medication that is a metabolite of morphine, or that has a metabolite of morphine? Heroin. So when heroin breaks down, it actually shows as positive morphine in the urine drug screen. So when you have a patient coming in and you haven't been given that patient morphine, but it says positive morphine in that urine drug screen, then you start wondering if they're either taking codeine or heroin, you know, those kinds of things. So we need to be aware of the other things that can potentially happen. Another one, hydrocodone is metabolized into hydromorphone, so one or the other. So let's say you're giving that patient oxycodone, Percocet, and not so much hydrocodone. That patient, and hydromorphone rather, you might see that there's a positive metabolite of hydrocodone in it instead of hydromorphone. So, you know, those things we have to be very, very aware of before we either discharge patients or start counseling them and telling them, why are you taking this? It looks like you're taking this, you know, those kinds of things. Some patients also, what they do is they either dilute their urine or they add adulterants. So for example, bleach solutions, contact solution, those kinds of things. So anything that, and if the urine starts looking diluted, don't accept those. If you're not sure, again, send it to laboratory already, because sometimes patients can get very, very tricky. And they research all of these things very well, and they start adulterating their urine to hopefully, prevent us from seeing what they're actually taking. False positive results can also happen. So for example, to look at this table, patients who are on these medications may show up with positive amphetamine. Patients on sertraline may show up with benzodiazepines, those kinds of things. So let's be aware of that too. And then in terms of duration, if a patient has been taking amphetamine in the past 2 to 3 days, it's going to show in the urine. Benzodiazepines, within 3 days, it's going to show in the urine. Cocaine, all those kinds of things. Alcohol is just about hours, 7 to 12 hours. THC will show in the urine for about 3 days. That's a single use. Obviously, for patients who have higher usages of this, it'll probably show in the urine even for a longer period of time. And so those are things for us to remember when we're interpreting these urine drug tests. All right, so follow-up visits. So now you've managed your patient, you've done all the things that you need to do, now you're following them up. These are really now very important for you to document. How is the analgesic effect? Is there continued justification for continuing to use the opioids? Is it helping? If the patient is still saying 20 out of 10, and last time she said 20 out of 10 or 15 out of 10, is it really worth it to continue with this? Should you start weaning? Maybe the patient's starting to tolerate this medication. A lot of those discussions need to come in. How are their activities of daily living? Are there any aberrant behaviors? Are there any neurological red flags, new symptoms that you need to investigate? Is there any diversion issues? All of those, very, very important to assess during follow-up visits and document. And then, of course, we don't want to forget about non-pharmacological interventions. So all of these have been or have evidence in the literature and in the guidelines. Acupuncture, for example, the endorphin levels of patients with chronic pain are very low. When you give them opioids, it's even lower. It even depresses those endorphin levels. So the idea for acupuncture is it helps stimulate that endorphin system. And that's why some insurances are actually covering them. Some, anyway. And then CBT, cognitive behavioral therapy, that has absolutely proven benefit. Anything that improves your endorphin system, humor, fun, those kinds of things, important things to talk about too with patients, what makes them happy. Try to get their mind off of the pain, those kinds of things. Sometimes we miss these opportunities with them. Problem with non-pharmacologic interventions in recent studies and in terms of complementary health is that not a lot of providers are using them. But it also comes with the barriers that we talked about earlier. Teresa pointed it out. There's insurance issues. So it's hard for us to then use things that we know have proven benefit in the literature, but then the insurances are not able to cover them. Interventional modalities are also very important. If you have an opportunity to join a pain practice that is interventional in nature, that would be a good way to go as well. A lot of pain providers only just do refills, pain specialists. That becomes very, very overwhelming. I think I got burned out after 4 years of seeing pain patients every day. From 8 to 6, we actually had a long day. When you're starting your NP practice, you feel like you just want to go out there and then you end up being burnt out. So you have to be careful. And especially when you're seeing pain patients every day, Monday to Friday, for that length of time, it's easy to get burnt out. So you want to be, you want to have some variety in what you're doing. In interventional pain practice, you have the opportunity to do some trigger point injections, joint injections, some procedures to kind of get your mind off of the usual, what's going on today, this is what we're going to do kind of thing, and writing prescriptions. So before the visits end, you want to make sure that the patient understands what you're doing. You give them the references and resources that are possible out there, what is available in the community, ensure that there's a follow-up. You document all of these. You open yourself to audit, record, whether it's within internal auditing between providers or hiring somebody outside. Those are really, again, best practices that you want to be able to do. because it gives you a fresh idea in terms of, well, how are you doing? And it's not just in pain management, it's even primary care in general itself, allowing your records to be audited by other providers, whether internally or externally. Those are always very, very helpful. Kind of gives you an idea in terms of how you're doing and what you might be doing better, those kinds of things, other than staying within guidelines. So this is a common patient that we see, pain everywhere. Sometimes you have, depending on the pain practice that you're going to be in, a lot of times we give them this map, a body, and then we tell them to encircle which part of the body hurts. It's not unusual that they would just circle the whole body. Everything hurts. And so then you end up having to manage these patients with so much medications, or you receive them as a new patient already in so many medications, you end up into scenarios that are quite difficult. The articles that I wrote in the Nurse Practitioner Journal has some tips in there. The guidelines also talks about some tips in terms of managing patients. And a lot of it boils down really to making sure that you base your practice on standards of care and best practices and evidence or clinical practice guidelines, so that you can hopefully make sure that you've not just helped the patient, you've also covered yourself as providers. We don't want to talk so much about just covering ourselves as providers. You want to make sure that there's efficient, effective, safe, quality care balanced with you doing all the best things that you possibly can do for that patient based on guidelines and standards of care. So we had this patient come to us very recently, arrives intoxicated or somnolent. I think I have 5 minutes left. It's all right. What do you do? What do you do when you have this patient come into your clinic? Tell them to go away. Nothing. Yeah, you do the usual history and physical and the assessment, right? We still go through everything. They're already there. If you're not going to take care of them, you're going to be in a liable issue, because then, what are you going to do? You still do what you need to do, and you try to figure out what might be causing this intoxication. So is it alcohol? Is it opiates? Is it a combination? Is it benzodiazepines? It's a medical issue, in fact. We don't want to go to judgment right away where it's a chronic pain patient with a lot of pain medications, and then realizing that, the patient started developing DKA because history of that, all of those things. So you want to figure out at least what might be happening for this patient at that moment, and then at the same time getting ER involved, and then getting that patient transported by ambulance. It's not a primary care patient situation. It's not something that you want to have to handle, but you do want to triage this patient and manage them as best you can while they're there, and then ensure that they get the proper care afterwards. After this, then you want to make sure that that patient, let's say it is an addiction or substance abuse disorder or substance use disorder, then you want to make sure that you have a patient referred appropriately to a specialist, wherever that might be. All right, motivational interviewing is something that the CDC also talks about a lot. I'm not sure if integrative care talk will be about this, but there's a really good case in that CDC app that talks about motivational interviewing. And the idea is, how do we better communicate with our patients so that we, in fact, affect change of behavior from them? Because it's easy for us to say, do this, this, and that, but how do we communicate? And these are just some tips that is being recommended. And there's some good trainings for motivational interviewing. Unfortunately, it doesn't merit a 15-minute visit. This is a visit that will definitely take so much time. And so it's important to make sure that hopefully you do have time for this patient so that you can really effectively get this strategy done. Current trends for anybody going, or at least for us in Nevada, again, I have to speak a lot about Nevada because I'm familiar with our state guidelines. I don't know how it is yours. Effective January, again, for us, we have to do 2 to 4 credits, I think, of opioid substance use disorder CEUs every renewal period. So again, those are one of our state regulations that we're having to do. Whether or not you prescribe opioids, it's something that you have to do in order to update your license. So a lot of the states are starting to do those now. REMS, risk evaluation and mitigation strategies by the FDA, talks about really making sure that we're informing our patients with the medication that we're giving them, and that we as providers are also educated and informed when we write this prescription. Because if you don't feel comfortable, you're probably better off not doing it. And hopefully the practice you get into wouldn't mind that at all. I have colleagues who, because we practice only once a week, we don't practice full time as faculty. We only practice once a week. I have colleagues where they've had conversations with their practice physicians and other providers in their clinic to where they've had agreements that they're not to write controlled substances. And so anybody who needs that has to go to another provider in that clinic. So, those are agreements and negotiations that you can do with your providers. You want to make sure that you start doing it when you're comfortable and aware and well informed. Not an excuse also for not being informed. We want to make sure that we know what we need to do in order to take care of the patient. But we have to be prepared and ready also. So the DEA has been cutting back on the prescription of opioids by a quarter already. And so we've had a lot of patients come to us sometimes from pharmacy saying, "Doc, they don't have this. What am I going to do?" And then you get pushed in a situation where you have to write something else. So you have to calculate the MME, do the equianalgesic dosing. The patient's probably going to come back to you and upset and irritated. A lot of times there's things that you have to handle, even if it's not necessarily your fault or your issue, but you have to be aware of once you get yourself into these situations. Genomic studies are coming up to try to see how medications can be better, what our genetics within us, what are the differences within us that may predict persistence or chronic pain, those kinds of things. So a lot of these are in the works, and they've been in the works. Unfortunately, we haven't gotten to a situation to where, for example, in diabetes, we know that there is a really great biomarker for blood sugar, your hemoglobin A1C, for example. It's easy to manage. It's easy to get that from the lab and then monitor how that patient's diabetes is. You don't have that in pain. Everything is still subjective. We may have functional MRA, which they say is getting better as a biomarker, but those things are expensive. It's not an easy thing to get, and it's not like you can, provide that order to your patients all the time. But we don't have biomarkers or biologic indicators for pain just yet. And so it's an issue, and a lot of our genomic studies are looking into these, but there's so much variability within pain, not just in terms of our gender, even our other covariates like socioeconomic status, the type of pain that we have, culture, those kinds of things that can impact these kinds of studies. So it's tough. And somebody talked about marijuana earlier. So far, we still have marijuana as a Schedule I drug, right? So there are moves by FDA and DEA to move the Schedule I drug into a Schedule II or to make it a prescription medication. Federally, it's still illegal to prescribe it. States have now gone in, some states, there's a few states who have actually used the word recommend or certify, but not necessarily use the word prescribe, but certify or recommend marijuana for pain. And some states have given NPs, nurse practitioners, the leeway to do this, but it's still not something that's open and wide out there. So I think a good question earlier was about the component, about the marijuana and pain. The main ingredients that are really active in marijuana is your THC and your CBD. The THC is the one that gives you that euphoric high effect, and the CBD is the one that doesn't give you that, but helps with a lot of the, not just pain, but seizures, a lot of the medicinal properties. And it's the CBD that they're really trying to hone in on. Nevada and California apparently has, we have Canadian big farm companies who came in and bought huge lands in there to grow marijuana, but that means not to grow marijuana, but actually what they mean is to isolate the CBD, which is the medicinal part of marijuana or hemp, and hopefully use it for eventual pharmacological purposes. So those things are coming up. Sure. And it's illegal for us as prescribed. So it puts us in a very bad spot because remember, when you prescribe opioids, you have to have a DEA. DEA is a federal agency. So it puts us in a very difficult situation managing these kinds of patients because of that federal versus state laws. So what the federal government is doing right now is, and I think we're on to our question and answers already while we're at it, because that's it. So that works out perfectly. So what happens is the federal law has stated that we're going to not prosecute, or at least, it's not something that they want written or documented, but they're not actively prosecuting as long as states have their own rules. Because obviously we know that some states already have allowed for medical marijuana as well as even recreational marijuana. But they have a hands-off approach at this point. Until something happens, obviously, then they do need to step in. But that's what puts us in a tight bind. And so, for example, in our facility, I don't know how they do it here, but in our facility, when patients come in and they test positive for marijuana and they're asking for controlled substances, whether it's an anxiolytic, benzodiazepine or an opioid, we don't give them. You just can't, And you then have to sit down with this patient and listen to their anger and then just go from there. But yeah, it's a difficult situation that we're put in that regard.
So we're looking at medical marijuana in our organization, and we're not finding the evidence. So in terms of pain evidence, are you seeing some things coming up now?
There isn't just yet, and the problem is, and the reason for that is because although marijuana has been around for a while, the CBD component of it and the pure use of that medication is still fairly new, that research is still kind of up and coming. And that's why a lot of these big pharma companies are, I guess, doing all of this huge buying lands and growing pot, if as they call it. But sometimes we have to make sure that it's, and some might be doing that in a bad way, but there are also those companies who might hopefully be doing it the proper way, which is isolating that CBD component so that we can have a really good evidence in terms of research. Because opioids, remember, we do not have long-term effectiveness evidence for opioids. There isn't any, which is very clear in the literature. Yet it's very clear in the literature that there is a huge opioid use disorder going on with prolonged use. And so where marijuana comes in, or the proponents for marijuana come in, is to try to use that CBD component of it in the area of research, and then hopefully then convince the government to do some changes federally, as well as rescheduling the medication to a Schedule 2 as opposed to 1. Yeah. Not so much on and it depends also on how much CBD oil they're using, right? So if it's something to where you have a patient with arthritis everywhere and they're spreading it all over their body, it's possible that you might see it within 1 to 3 days of use if you're able to catch that urine specimen within that time frame. May not stay longer than 3 days, probably 1, almost like alcohol. But if it's just topical, little bits here and there, it's not going to pick it up. But the problem with this too is we don't want to reassure patients so much about that either, because of the lack of purity of some of the CBDs and where they were purified or purchased. We don't know if it's totally pure CBD or if it has other components in there that can come up in the urine and get them in trouble in their jobs or whatever. So, and that's a good question that patients usually come up with because they don't want to get in trouble. And so we want to make sure that there's a little bit of reassurance there, but there's also a lot of fact so that they're aware of potential repercussions if it indeed comes up in the urine. adverse childhood
events.
events. Um, I,
And people who have adverse childhood events tend to have higher propensity for cognitive and much more challenging pain experiences.
right. I think our screening talks about trauma. So the screening that we use uses the word trauma. So whether it's happened way back in the past, as in childhood, rape situations, anything that might have happened, abandonment, all of those things from beginning to old, to older age, we have that, and that's really a very important point because again, psychological factors influence a lot of our pain and the chronicity and disability and lack of employment and healthcare costs and those kinds of things. So we want to make sure that we assess those as well, other than just their mental health status, because that is actually part of their mental health status in terms of what their history might have been in that regard. Yeah. Any other questions or thoughts? We haven't used that a lot. They've done what we've done for central pain is lidocaine infusion, and it's monitored. We do EKG monitoring. Lidocaine works through stabilizing the neuronal membrane, so it works very well for neuropathic pain, whether it's peripheral or central. So it helps with that rapid firing of the nerve fibers. So we've done lidocaine infusions. And we've gotten good success with those. Not so much ketamine. I haven't seen that as much. I think maybe pediatric population, they might have that, not so much in the adult. I do more adult population than the pediatrics.
What do you think is the biggest barrier that you'd like to transform what you've developed in the chronic?
I think it's just providers, either we're not fully aware of this, we're still scared, or we just don't want to touch it, period. We just want to say, I'd rather not manage, and which is, it's not necessarily a bad thing. If you don't want to manage it, then refer, right? Make sure that the patient still has access to care. But you don't want to use that as a rationale for then increasing the morphines and the fentanyl prescriptions, because that's probably not a good idea either. Because buprenorphine has its good, the advantage of it is, again, it doesn't have that, or it has that ceiling effect. So when patients take so much of it, it's not going to make any difference, unlike opioids, for example. So I think part of it is really providers themselves. And number two, the patients as well. It's a new medication. They know more about OxyContins and morphines and fentanyl and all that. So they're going to think, especially for those who've been established on this medication, they're going to think, oh, that's not going to help, already having those preconceived ideas. So it's going to be a matter of really talking to the patient, sitting down with them, and really making it to where hopefully they do understand. The problem sometimes is when people have set in their mind already that this is not going to work, it's probably not going to work. And then you're going to end up with an unhappy patient at the next visit.
Do you take into consideration ethnicity when starting opioids and like rapid metabolizing or
Yeah.
slow metabolizing?
Yeah, Asians, for example, so remember when we talked about CYP inducers and the inhibitors? Asians and codeine don't get along very well. Either it doesn't work for them, or they get very deathly sick. And it goes back to that CYP, liver enzyme detoxification, metabolism, plasma clearance, all of those kinds of things. There is actually some genetic testing that they do and that insurance can cover for patients where you've tried and documented in your records where you have said, I've tried this patient on this different medications and somehow I'm not getting the pain relief. Then you do some genetic testing, and then it shows them CYP inducers, CYP inhibitors, any kind of other enzymes that it's picking up specific to that patient that may be impacting absorption or metabolism of their pain medications, particularly opioids. So we do have that. And Aetna, for example, we've done that to a couple of patients. Some of the PPOs have covered it. Again, it's about making sure that you document to your rationale and your justification as to why you're doing it, because once then you have the data, then hopefully you're able to manage this patient more appropriately. Morphine, the advantage of morphine, that's why a lot of people like it, is not impacted a lot by our CYP enzymes. And so whether you have an issue or a gene lacking into a CYP inducer or inhibitor, morphine is not affected by that as much. And so it's one of those medications which is easier in terms of managing. Fentanyl is very difficult. Fentanyl, I mean, more difficult than we think it is. Remember our example earlier with the amiodarone and the fentanyl, CYP inducer and inhibitor. Yeah. Hopefully if it's nociceptive, then you can use you would have justification to convince that patient that NSAIDs and acetaminophen or your adjuvant agents will help or can help better. Or if it's some neuropathic, then hopefully your SNRIs or even SSRIs, as opposed to using some opioids. Worst comes to worst, if you have a difficulty with these patients, I would say refer them. For patients who are comfortable, for providers who are comfortable with methadone, starting them on a small amount of methadone. Methadone helps with pain, it helps as an analgesic. And at the same time, it's okay for patients who have a history of even active substance use disorder. And so starting them, if you're comfortable and you know the patient very well, starting them with 5 milligrams BO twice a day would be okay. This is a patient that you want to be able to be following up really closely, having them come in. And you can be justified, or usually, from what we've seen, we haven't had issue with insurance coverage. We might see that patient every week until we kind of get that patient stabilized. It goes back to documentation. If we don't have enough data in there, then the insurance will come and say, you're seeing this patient too frequently, or we're not reimbursing you for this visit, those kinds of things. So it goes back to making sure that you're documenting why you're doing what you're doing. But methadone is a good one for those kinds of patients. And if you're comfortable, Suboxone of 4 milligrams would be fine. And if you're not comfortable, then you're not. So just have your arsenal of providers who would be open and hopefully available for you to use during these kinds of situations where you need help like right away instead of 3 months out. Any other questions and thoughts? Everybody hungry? I think we're good. No other questions, right? Thank you so much.